today is Dr. Andy Gray. So Andy is a pharmacist whose research interests include policy analysis related to national medicines, rational use of medicines with the overall goal of improving public health outcomes. He is currently a senior lecturer at University of KwaZulu-Natal in South Africa and advises various actors such as pharmacy associations, national authorities, and WHO groups on topics related to healthcare solutions and improving health outcomes across Africa. As an academic, he has published several articles, served as reviewer for a number of international and local journals, and is involved in reviewing grant proposals. So Andy, delighted to have you here, and over to you. Thank you.
Thanks very much, Padma, and good morning, everyone. So it's my pleasure of the speakers. We are going to hear first from Jocelyn Chaibva, and then we will move on to a series, first a doctor's perspective, then a series of case studies before we come back to the regulatory perspectives. But before we do that, just a few opening remarks from me. I don't want to steal our speaker's thunder today, but just a few opening remarks. So next slide. So as I said, after my introductory remarks, we'll go to Jocelyn Chaibva from FIP, Dr. Marlon McKay giving a doctor's perspective, and then we'll get into the case studies. Daniela Munene from Kenya, Sham Mudli from South Africa, Mazisamu Abunwa from Nigeria, and Noafel Amira from Tunisia. And then come back to a regulatory look. One from Louis Machogu from Kenya, and then Marit Ekstien from South Africa, before we open it up to a panel discussion and some closing remarks from me. Next slide. So what are we talking about today? We're focusing on self-care, and WHO's working definition has some really important elements to it. It defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without the support of a healthcare provider. So that's really key. And in addition to the normal lifestyle choices and habits that could be part of a holistic self-care, this also involves responsible use of prescription and non-prescription medicines, self-recognition of symptoms, self-monitoring, and self-management. Next slide. The key is that self-care does not rule out the involvement of healthcare professionals. And nurses and pharmacists play an important role in self-care, and that's been really brought to the fore during the COVID-19 response. Our focus today will be on pharmacists. They are typically a patient's first point of contact with the healthcare service, and they offer a range of services and products which have been really important during COVID-19, be those drive-through, telemedicine, medication deliveries, as well as the products used to manage COVID-19. Next slide. So the point we want to make is that COVID has put self-care under the spotlight and proved its integral role in healthcare. And pharmacists have been able to step up, not only because of their normal functions, but because of the fact that regulatory systems have enabled them to do more than they have in the past. So modifying prescriptions, extending repeat prescription durations, dispensing alternatives without consulting a doctor all around the world. There have been efforts to improve continuity of treatment during disruptions. Next slide. So what is the future of self-care? There's a changing landscape with increasing digital and technology interventions, but pharmacists will still be core healthcare professionals in that. There's still a focus on individual empowerment, but importantly, if we think of this, the SDGs, self-care is one of the building blocks of universal health coverage. It has both an economic role and a health promotion role. And we can ensure that there's global knowledge transfer for better global health by sharing our experiences, but taking responsibility for each of our roles within global self-care and within universal health coverage as a whole. So that pretty much covers my introductory remarks. And it's then my pleasure, if we go to the next slide. Can we get next? So the next speaker is going to be Jocelyn Chaibva, who's Vice President of the African Pharmaceutical Forum, which is a structure within the International Pharmaceutical Federation. Jocelyn is based in Zimbabwe, our neighbor to the north of South Africa, but has wide experience of the challenges of pharmacists across the entire African continent. So it's my pleasure now to hand over to Jocelyn to give us some introductory remarks on the evolving role of pharmacists. Thank you, Jocelyn.
Thank you, Andy. Can I please my first slide? Thank you. I'm Jocelyn Zimbabwe, talking about the evolving roles of pharmacists. Next slide. When I think about pharmacists and the way medicine is happening, or how pharmacists are operating in different countries, it brings me to the theme which is used by the Pharmaceutical Society of Zimbabwe. The logo is actually times change and we change with the times. This is an old theme from our forefathers, or the ones who started the Pharmaceutical Society of Zimbabwe before my time. And it still applies today. Times change and we change with the times, and this is transformation. So in this perspective, we've got a one FIP concept from the FIP, of which I'm the vice chairperson of the African Pharmaceutical Forum. It's one of the forums which work under FIP. So the concept of one FIP concept is wherever there's a pharmacist, the objectives is more or less the same: to improve medicine use and promote therapeutic benefit for the patient, of course. So it benefits the patient, and it applies at all levels of pharmacy practice. That is, whether it is at international level. So at FIP, we discuss it as an international organization. At APF, as a regional organization. And there are also other regional organizations like the Euro, which deals with Europe, or CFM, and so on. And then at national level, we have our societies. Like from where I come from, we've got the Pharmaceutical Society of Zimbabwe and its affiliates, like the community pharmacists, the manufacturers associations, and so on. And what we are looking at is to improve medicine use and promote therapeutic benefits through the supply chain within the pharmacy system. Next slide, please. Right. One FIP concept is based on a FIP development goals, which are actually adapted from the Sustainable Development Goals. The SDGs, there are 17, but FIP has made it clearer by actually opening up to end up with 21 FIP development goals, and these are available on the FIP website. And each of those goals is worked through practice. How does it affect practice? How does and the science behind it? And it involves the workforce development and education of the practitioner, so that this development can be these development goals can become a reality. So FIP is the International Federation, and it engages member organizations and colleagues, and it has got it works with other bodies like WHO and so on. And at a regional level, we've got a pharmaceutical forums like APF, which is the AFO, which is under the Africa region. And then we've got Euro or Eastern Europe and so on. And then national level, as I alluded to earlier on, associations like Pharmaceutical Society of Zimbabwe, Pharmaceutical Society of Kenya, and they also have their subsidiaries like the community pharmacies and so on. This provides description, direction, and context of each goal, because what happens in different countries is also affected by the legislation. And as such, there's also a regulatory aspect to this. So you find that the associations at the national level, they actually want to manifestation of, or the outcomes based on these development goals can actually come to life through these associations and the members in those associations. An outcome of FIP development goals is to mobilize global pharmacy development and transformation through development. There's of the pharmacy workforce, so that we end up one with the pharmacy practice through appropriate education based on appropriate scientific principles. It's not just like at the snap of a finger, we're going to change things. It's all well thought out so that it can actually be worked throughout with all the other different countries, can actually make sense out of it. And I'm sure as we celebrate the World Pharmacist Day on the 25th, these will be some of the issues which we want to strengthen or highlight in the role of the pharmacist. So community pharmacy transformation is based on supporting the 4 pillars. Next slide, please. So the 4 pillars of community pharmacy best practice. Historically, when you look at pharmacy, there's manufacturing of galenicals, the pills, creams, and ointments, or even on a small scale, because it was in the pharmacy. But with the improved technology, we have found that when you look at historically the development of movement in the supply of medicinal products, there's now large-scale manufacturing, which is more efficient with high standards, and makes use of the economies of scale. There's now time for more clinical roles for the pharmacist, because you'd find that in that setting or the old setting, it will be more trying to just provide the product, and the product without adequate education for the patient can be poisonous. So the pharmacist has to be more involved in clinical roles, and this empowers the patients. So the 4 pillars of pharmacy practice under community pharmacy practice, FIP, highlight the evolving roles of the community pharmacy practice. As I said earlier on, we change with the times. One, we are looking at reviewing of prescriptions, so it becomes more working with the practitioners, so that if there's a prescribing which is irrational and so on, so the pharmacist works together with the other healthcare professionals, so can also prescribe or initiate treatment. The prescribing pharmacist role, especially this has come to light or strengthened, the need has been strengthened by the current COVID condition. And then the pharmacist also dispenses and administers. In terms of administering, we also talk about vaccines. This is where it comes into place. And this is the era in which vaccination as a method of prevention, primary health care, has to be strengthened. Next slide, please. So the changing roles of the pharmacist, as I alluded in the previous slide, is reviewing of prescriptions, including pharmacovigilance. So you are looking at safety of the medicines when you give it to the patients. Prescribe, initiate, plus educate the patient, so that there's more self-care. The patient understands their medicine and they make the best use for their medicine for better outcomes. And then dispensing of the prescriptions with the education along with that. Then administration of medicines. What comes to mind at this point in time was the need for vaccination. So as FIP, there have been series of lectures on transformation on vaccination called the Transforming Vaccination Series. This is to empower the pharmacist to administer medicines, especially when we are looking at increasing the access to vaccines during this COVID pandemic. A number of countries are already doing it. In Africa, I know South Africa is already doing it. Here in Zimbabwe, our pharmacists are undergoing training so that they become vaccinators. So we're making inroads to try and promote these roles of pharmacists. Next slide, please. In conclusion, the role of the pharmacist is continuously evolving, and we don't stop. Things change, and we change with the times. And right now, there's no better time for introduction of development goals. It is what I would call God sent, and it's in line with what is happening around us. And that also involves lifelong learning for all, including the patients. So it's not just the practitioners, because things are changing and we need to move with the times. So patients should be empowered through knowledgeable pharmacists so that self-care becomes part of normal health care as we move towards universal health coverage by 2030. Thank you.
Thanks very much, Jocelyn, for those introductory remarks and for setting the scene so well for us. We're now going to shift over to Dr. Marlon McKay. He's a general practitioner from South Africa who works at the Goldman Medical Center. And Jocelyn will give us the medical perspective on self-care beyond COVID-19 in Africa. Marlon, over to you.
Good morning, everyone, and thank you, Andy, for that introduction, and thank you that I could be and participate in this important webinar. So I'm a GP in South Africa, in Johannesburg, on the western part of Joburg, called Roodepoort. I'm in private practice for the last 30 years, and in my particular area, I have. Can you please advance the slides to my first one? In my particular area, I'm surrounded by 4 independent or community pharmacists with whom I have an excellent relationship because of the understanding that we have amongst each other. So I just want to give you a little bit of background in terms of our historical relationship. Next slide, please. So over the years, we've encouraged a relationship in which we get to know one another. We have all the cell phone numbers. I'm available after hours. I need them to get to know my handwriting. I pride myself on a good handwriting, but more lately we've been using electronic prescriptions. They've gotten to know my prescribing habits, and they can see when something is out of character. They have the freedom to call me when they think I could have made a mistake on the prescription. They assist me with drug interactions, especially where I could have missed something, in particular with ARVs and sort of PPIs, for example. And I have full confidence in them in the sense of the way they relay my instructions to my patient, exactly to the way that I have prescribed it. And so we've developed a good working relationship, and ultimately it is the patients who benefit from this conducive relationship. Next slide, please. And so in discussing what the role of pharmacists are in increasing access to healthcare, I'd like to just use asthma as an example, because it is so prevalent, and the WHO informs us that asthma is currently the most common non-communicable disease, which affects over 260 million people globally. This is the figures from 2019, and causing at least 461,000 deaths. The problem is that most of this morbidity and mortality is associated with asthma is actually preventable.
De mortalité associée à l'asthme pourrait être réduit grâce à l'utilisation de corticostéroïdes.
And updated more recently. Please give me the next slide. We have the GINA guidelines, and this marked a landmark change in asthma management. And for safety, as you can see there, GINA no longer recommends SABA-only treatment for adults and adolescents. And of course, this decision was based on data that showed very, very clearly that SABA-only treatment for asthma actually increases the risk of asthma severe exacerbations. And what we've come to realize now is that any inhaled corticosteroid actually significantly reduces this risk. Next slide, please. And of course, the major issue is our patients' over-reliance on SABAs. Our patients want treatment that provide immediate relief. And again, Gina brought to the fore that using 3 or more canisters, SABA canisters per year is an indicator of increased risk of severe attacks, increased risk of hospitalizations, increased risk of oral corticosteroid prescriptions. And so we know that on most of our scripts, we put a inhaled SABA repeat time 6. And yet what we are now saying is that we should refrain, our patients should refrain from the over-reliance of SABAs to reduce the risk of exacerbations. Next slide, please. And so the critical role of the pharmacist in this relationship, and in particular dealing with asthma, is that we need to make sure that our patients are not overusing. And as pharmacists who are the first port of call, we need that assistance in terms of educating patients of the benefit of using their controller medication on a daily basis. Please advance for me. And generally, as I said, patients want quick relief, and the SABAs give them that, granted, but they think that is meaningful asthma control. Next, please. And so we need to have a shift in our mindset for patients to use the preventive medications over the quick relievers. Please advance. And so even when patients feel well, even when they don't see a need for SABAs, they need to continue using the inhaled corticosteroids. Next slide, please. And so for me, this is such an important slide, because when we are going to, if you are going to manage our asthma patients very, very well, effective self-care of asthma requires this active collaboration, intense communication between my asthmatic patients, myself as the treating healthcare professional, and my local pharmacist. We need to be on the same page. We need to be aware of the latest GINA guidelines. We need to be aware of those patients who are over-relying on SABAs and underutilizing inhaled corticosteroids. And this relationship, for me, is critical if you are going to do anything to reduce the global burden of morbidity and mortality around asthma. Next slide, please. And so for me, this critical role, and I'm so glad that Andy started the discussion by saying self-care does not rule out the role of the healthcare professional, because the last thing I would want as GPs is to be excluded from this relationship. And so for me, if I look at just from the COVID experience over the last 3 months, what has benefited my patients and benefited my practice is the critical role of pharmacists in the way that they open their practices for longer hours. The pharmacists, they were a reliable source of information when we weren't available. I spent the last 6 or 7 weeks working remotely from home. I just had to have a locum here. So we had limited hours, but the pharmacists covered up by being open and accessible. We did lots of telemedicine. I could email scripts. I could even WhatsApp to the chemist, WhatsApp the script to the patient, and the patient could take that to my local pharmacist. They have great assistance during critical drug shortages, where they could switch because of of our relationship. They could switch comfortably without even contacting me. They could dispense comfortably and make sure patients didn't leave the pharmacist without critical medication. There was very, very good communication between myself and my pharmacist. They assisted in counseling of patients in the delivery of medication. They had scooters and motorbikes all over the show delivering. Having COVID, of course, you had to be in isolation, so patients couldn't leave. Sometimes whole families were affected. And so this whole pandemic allowed strong relationships of trust that could be forged. Next slide, please. And so they really helped me to alleviate the increasing burden on the healthcare system. They reduce costs, they utilize resources adequately. And the focal point of this whole pandemic has been the patient, making sure that the patient is cared for, has their medication, and even without the hassle of leaving their home. They assisted when I was not available in managing patients' minor ailments, complaints, and without costly and time-consuming visits, bearing in mind I wasn't even available for that thing. And so together we ensured that there were safe and effective self-care treatment options available for our patients. Next slide, please. I think this slide is well known amongst the self-care, so I won't go over that. If you can please advance again. So the critical question, am I as a healthcare professional ready to embrace the sort of change where the pharmacist can increase the role. And if you look around me at my fellow colleagues around here, I think there has been a reluctance on the part of some of our GPs to allow pharmacists to take on this greater responsibility. Have we been prepared, especially if you look around at the COVID pandemic? Do we feel that our pharmacists have been adequately trained in managing the needs of our patients? And I think there is a sense that we would like our pharmacists to adapt quickly, to train themselves and be able to interact with patients, especially with the rapid pace of change in medicine. They must become leaders in digital health solutions. We are all moving to the digital telemedicine, really beyond their practice settings, thinking outside the box and expanding their horizons. And so the feeling is that we need well-trained modern pharmacists who are able to adapt to any new modalities, whether it be patient education, patient management, and services rendered. Next slide, please. And so on the whole, we are very receptive to the increasing role of pharmacists advancing patient self-care, assisting us with compliance, medicine information, over-the-counter medication, cost-effective prescribing, and we feel that I can trust them with that. Obviously, how willing are we to endorse their services, especially those services that are traditionally associated with the GP? We don't want to feel isolated or pushed out. And so we are supportive of wider medicine availability and increased range of medication that our pharmacists can prescribe. Next slide, please. And so I think in closing, are we ready to embrace change from a doctor's perspective? It really comes down to how happy are we with the pharmacist's ability and readiness to embrace that change? And then how reluctant are we to allow our neighboring pharmacists to take on that greater responsibility? And I think personally, as the question is from a doctor's perspective, I am ready on both fronts. And the COVID pandemic has essentially taught us that this can be done. Next slide, please. And we can work together to embrace that change, ultimately for the benefit of our patients. Next slide, please. And so the critical role really, or issue, comes down to communication. There must be communication between doctor, patient, and the pharmacist. The pharmacist needs to know the background of the patient, the medical history, the medication that they are on. Help us with screening. Basic screening can be done in a pharmacist, the patient without a visit to the doctor. Make sure that the equipment is up to date and specific for specific conditions. Able to provide objective information and medication, especially within the realm of funders and payment of certain medication. And again, expanding the range of self-care medication that can be dispensed to the patient and making sure that we protect patients' confidentiality and information. So the setting within the pharmacy must be conducive to that level of comfort. So from my side, I am so happy that I could be part of this so that we can work together and increase the role. We need them. We need that role to be increased so that our patients ultimately can benefit, and health and medicine can benefit within my particular community and within the greater perspective in South Africa. Next slide. I think that was my last one.
Thanks. Thanks very much, Marlon. That was wonderful. And thank you for giving us a link there as well. We can follow that up. Very positive, very encouraging perspective from the medical profession. We are now going to move over to a series of case studies. So we are asking pharmacists to share their actual experiences, not the potential, but the actual, what is really happening on the ground. And we are going to start with Daniela Munene, who is the Chief Executive Officer of the Pharmaceutical Society of Kenya. And Daniela will share with us her experience of pharmacists as gatekeepers to self-care in the Kenyan environment. Thank you, Daniela.
Thank you, Andy. Please confirm that you can hear me clearly.
We can, perfectly.
Great, thank you. So I'll just give a snapshot of what we've learned in terms of pharmacists driving self-care, because we've had several initiatives where self-care has really been driven from the community pharmacy mostly. Next slide, please. So pharmacists as gatekeepers, if we think about pharmacists practicing in different areas, We have pharmacists in industry, so they're responsible as part of a larger team to formulate and design products for self-care. So self-care is not just restricted to community practice. Even those of our colleagues in industry have a role there. In terms of community practice, at least in this part of the world, pharmacy is both the first and the last point of call for health seekers. They start there and they'll end up there. So we're very uniquely positioned. Clients seek information to help them make decisions for their health. They want to know, will you treat them right there at the pharmacy? Will you refer them? Will you advise them? You know, and so we're a trusted source of information for our clients. And we, of course, we must provide information in a non-judgmental and confidential fashion as community pharmacists. But there's also pharmacists in academia, public health, administration, regulation. All these, in one way or the other, impact self-care. For instance, those of our colleagues who work for the national medicines regulatory authorities, they have to evaluate these self-care products and see that the information and the design is suited for client use. Next slide, please. So we need an enabling environment in order for us to fit into our role of driving self-care. One of the aspects of the enabling environment is we need a trained health workforce with up-to-date pre-service training and even in-service training. So for instance, if there's products that have come out that are designed for self-care, so we need to learn about them. Maybe we've already finished our pharmacy degree. We need, constant, continuous professional development to know how to advise clients about these products. Of course, we need commodity security. Once these products are out in the market and clients are used to using them with or without the intervention of a healthcare provider, it's important and ethical that we make sure that these commodities are always available to them. We also need supportive laws and policies so that maybe a product that was previously only for hospital use and now it's for self-care, the approval, the market approval and other policies.
Soit mis à disposition pour l'autoprise en charge, il faut que la politique et la législation le
so that people are not accessing substandard or questionable quality products. We need collaborative practices, as the previous speaker has alluded to optimize referral systems. And so we need a collaborative setup where if a client comes to our pharmacy and they need to see a medical practitioner, a consultant, then there's a clear path and a clear communication to the client about where to go. We also need strong reporting systems. At least in our case here, the community pharmacy, the private community pharmacy has largely been excluded from reporting to the National Health Information System. And so as more and more products are offered, products that were previously on national programs, for example, contraceptives, injectable contraceptives, they're being offered through the pharmacy channel, then we don't want to lose that data so that we can better make decisions nationally. So we need to plug in the community pharmacists to the National Health Information System. And in terms of just plugging them in, that's not enough. We also need to change the reporting tools so that we can disaggregate the services and products to know which ones were provided by a healthcare professional and which ones were the client went with at home for self-care, because this will really help us to see the uptick and the issues arising. Next slide. So that was just a background of generally the role of pharmacists and the enabling environment. Now I'll give you two case studies of what we've actually done in Kenya. So the first one is on HIV self-testing. And so, we partnered with other partners. There was Chai, Orashore, LVCT, and our members, our network of pharmacies. And we piloted the sale of HIV self-test kits in private pharmacies. This was the first commercial pilot outside of a formal access initiative. And this was guided by the Ministry of Health implementation guidelines for HIV self-testing in 2017, which allowed for these HIV self-test kits to be availed through the pharmacy and for the pharmacists to even be able to carry out the test, because there's always that initial case with a self-care product where the client is not confident to administer on themselves, and that first time they might ask you as a pharmacist to do the self-test for them or to demonstrate. And so at that point, community pharmacies were allowed to carry out that service in 2017. So the guideline came out, so the policy was allowing this, and as PSK, we jumped on that and we piloted a program. And so the objectives of the project were to avail the test kits for retail and community pharmacies, to test the operational guidelines and understand the modalities of providing the kit in the pharmacy. Remember, HIV tests, HIV products are usually already paid for by supported programs. So this was the first commercial kind of intervention where patients were going to use their own money to buy these products at community pharmacies. So we wanted to test and see if this will work. We also wanted to test the level of referral or linkage support from the pharmacy, the level of counseling by the dispensing pharmacist. We wanted to profile the typical clientele buying the kit. We were also assessing the price acceptability / willingness to pay out of pocket. What was PSK's role? We recruited and trained pharmacists for the pilot, and we developed normative guidance for the sale and distribution of the test in community pharmacies. As you can see on the right-hand corner at the top, those are our guidelines, and we shared them with our members. We had some challenges. We realized that there was a price barrier for most people because the price was, it was retailing to the client at between $7 and $12 US. That's 800 to 1500 Kenya shillings. So some people just were interested in the product because they could see the information displayed in the pharmacy, but then they would not go ahead and purchase the product. There was also, after a while, there was infiltration of non-quality assured, non-approved HIV tests, such as those meant for laboratory use, then started selling in pharmacies for self-use. So we realized there's a gap there. We've made a lot of awareness about this HIV self-test kit through community pharmacies that are licensed. And then, we had some quality, we had some infiltration of some dubious test kits in the market, just taking advantage of that kind of market publicity. We had some successes. They were well received. The kits were well received because they were easy to use. And to date, we have over 400 pharmacies in Kenya providing self-test kits, and they are now retailing at a lower price because of market. Many entrants came in, and so the price was pushed down. And the way forward is that 4 years into the sale of the test, it's clear that pharmacists are the gateway and the primary point of knowledge on HIV self-testing to the general public. We should be vigilant and reject non-approved kits as we would counterfeit medicines. And we should continue.
Comme les médicaments qui ont été faussés. Ensuite, assurer l'autotest et continuer de nous former.
Coming out of school on provision of HIV self-testing, because it's not just about selling the kit, it's counseling, it's demonstration, it's actually carrying out the test if so required, and it's also reporting to the necessary authorities in terms of use of the kit, and in terms of when you notice a questionable standard kit, you need to report to the regulator. Next slide, please. The second case study is on DMPA-SC. This is a depot IM injection for contraception that's been there in the market for a long time. It has always been available as an intramuscular injection. And one of the manufacturers of DMPA IM developed this subcutaneously injected product as a self-care product for self-use. And so I think this was very groundbreaking because it meant that women no longer have to go to a health facility to be injected this product. They can actually buy it from the pharmacy or from the healthcare facility and have it injected at home. So the background is that we have 18.6% unmet need for contraception in our country. So we need to increase the reach of modern contraceptives, and we need to increase the points of access to these contraceptives. Private pharmacies are already the major access point for condoms and emergency contraceptives. They also play a significant role in access to combined oral contraceptives. So we need to leverage all this that is happening in the pharmacy to provide more methods to reach more clients. And the first DMPA-SC product was granted market authorization for self-injection in 2018. So again, we jumped on that opportunity, that policy enabler, and you know, I'll tell you the journey a little later. Pharmacists can and should provide accurate and simplified health information on contraceptive options. We should also be able to evaluate the medical eligibility and select a suitable method together with the client. And then we should either supply or administer or refer for the selected method, because there are those methods, for example, implants, that we're not trained to provide or even allowed to provide at the community pharmacy. But the client, by the time they leave the outlet, should be very well aware of what works for them and where they're going to get it. So here's our journey of expanding family planning services through the pharmacy channel. In 2018, the family planning guidelines, national guidelines, were updated, and they allowed pharmacists and pharmaceutical technologists, if trained, to provide injectable contraceptives. So there was that caveat, if trained. In 2019, the policymakers, which is the Ministry of Health, the Pharmacy Poisons Board, that's the regulator, ourselves and other partners, developed a curriculum for this training of pharmacists and pharmtechs to provide these contraceptives. In 2021, this is earlier this year, we uploaded all registered pharmacies to the National Health Information System so that they can report the reproductive health services and products that they are providing. And right now, we are rolling out training using that curriculum. We're training our members, and so more and more of our members are starting to provide injectable contraceptives, both IM, subcutaneous, at their pharmacies. And of course, they're able to onboard clients, or rather give education to clients of how they can go and self-inject. And we hit some supply chain challenges where the DMPA-SC was not available for some time. And so now, because there's demand from the pharmacy, there's demand from the clients, we're having conversations with partners to secure stocks and avoid stockouts. Next slide, please. So in the context of COVID-19, we have an opportunity here to ramp up self-care because people are preferring to get their service from the pharmacy because they want to minimize their chances of exposure to COVID. And then the pandemic has increased the policy and implementation imperative to avail health seekers with more self-care options, more readily available health information, and remote access to services through digital health platforms. So countries should consider implementing existing WHO self-care guidelines. And I know in particular, one of the guidelines is that WHO recommended that countries relax their requirements for a prescription for self-injectable contraceptives and to enable pharmacies provide multi-month prescriptions so that the client can have enough, probably 5 injections, because the injections are, the DMPA-SC goes for 3 months. So if they can have for a year, those are just four products, then it will ensure that we don't have a dip in the access to contraception because of COVID, that we should not lose the gains we've made in advancing modern contraceptives just because we have a pandemic. And pharmacists are right in the middle of that discussion. I think this is my last slide. Next slide. Yes, thank you very much. I hope I have clearly presented our case studies and probably inspired the listeners to, to go out and implement some of these things through the community pharmacy channel. Thank you. Back to you, Andy.
Thank you very much, Daniela. I see there is a question directly for you from that's coming from the audience. what are the counseling requirements and the counseling training requirements for HIV testing? Can you just give us an idea of what pharmacists had to be trained on prior to being able to sell HIV self-tests?
Yes, so there was already a package of what the HIV counselors need to know, and this was from the government institution responsible for HIV testing. They're called NASCOP. And so we just used that in our pilot. We used the existing NASCOP guidelines to train our pharmacists. I mean, I could share that separately, but it's an entire guideline. And so that's what we used. We generally, as PSK, try to develop, either if the existing training material is not there, we develop jointly with government, or if it's already existing government, we just take it and access it to our members.
Thanks very much, Daniela. That was very clear. So our second case study is going to come from Sham Mudli, who's vice chair of the Independent Community Pharmacy Association in South Africa. And Sham has been very closely involved in developing new services in community pharmacy, including during the COVID-19 pandemic. Sham, over to you.
Good morning. Thank you, Andy. If I can get my first slide, thank you very much. Good morning, everyone. It's a real pleasure to be part of this African initiative. And I bring you greetings from pharmacy colleagues in South Africa. And of course, what you're seeing there is my beautiful city of Durban. You can see it's quite a mixed first and third world city. Next slide, please. So I want to suggest that self-care in South Africa, as in most parts of Africa, Asia, South America, for example, and many other parts of the world, is soaked in tradition and culture. The significance for pharmacy then is that we have an existing behavior pattern and a really captive audience based on the fact that they already utilize self-care in their own traditions. Next slide, please. So the challenge we face is to link self-care to pharmaceutical care. So according to a Hepler and Strand definition, pharmaceutical care seeks to achieve the outcomes of improving a patient's quality of life, not merely in the sale of a product. And this is critical. So to achieve this, we need to ensure patients have easy access to trusted healthcare professionals. Our healthcare system is evidence-based, and that pharmacy can provide a cost-effective solution for clinical outcomes. Next slide, please. So evidence suggests that there is successful demand market for medicines categorized in the Schedule 1 and 2 space, traditionally allocated for control by the pharmacist. The 27.8 billion market in South Africa is driven through physician prescriptions, around 77%, and 23% being directly prescribed by the pharmacist. So the question then is, are we getting the best value for our spend? Can we do more in partnership with our physician colleagues to strengthen the value? Have you moved ahead of me? Can you go back one? Okay, move forward. And the next one, thank you. Thanks. So in terms of volumes, you can see on the graph on the left, the high volume of medicines dispensed, which in itself indicates the lower cost pharmacy strategies already in play in different disease modalities. And this is quite important, that we are utilizing spend within a country and within a framework in the self-care environment directed by pharmacists. Next slide. So there are substantial risks in what we do, and we've been engaging on the risks of self-care and attempting to provide solutions. The codeine overuse is a good example, And pharma, together with pharmacy, are working closely with the regulator on a codeine care project, ensuring better control and access to pain medication. The main solutions to ensure we mitigate all of these risks are firstly, for pharmacists to take better control of medicines in their care, moving from the concept of over-the-counter to pharmacy-initiated therapy. And I think this is critical to us finding a solution on the issue of risk. The second is to create an informed patient base by engaging and assisting in their decision-making. So what we are heading towards is self-care with sufficient patient knowledge. And thirdly, to ensure a science-based algorithm approach to self-care. Next slide, please. So this looks quite complicated, but just to give you an example of the impact of pharmacy during COVID. So COVID-19 created an exceptional demand both in prescription medicines and pharmacy managed care. The first spike in both the slides that you see relates to the panic buying when COVID-19 was first diagnosed in South Africa. The second and third spikes relate to demand in the first and second wave in South Africa. The graph on the right indicates the steep demand on pharmacy in the area of respiratory conditions, gastrointestinal, and musculoskeletal medicines, and of course, some of the vitamins that we utilized during COVID. So you can see the substantial spike in the demand through pharmacy during the COVID times. And these are pharmacy-initiated therapy, or what is sometimes related as OTC medicines. So the other issue that during the COVID time, post-COVID, is that currently pharmacy is the largest driver of the vaccine delivery in the private sector in South Africa. And we do about 70% of all private sector vaccines currently. Next slide, please. So just focus on the bottom graph, not the top two. The bottom picture illustrates the year-on-year demand from last year, from the start of COVID to May this year. And this increase has been around 17.5%. So you can see the level of participation pharmacy had in COVID. Next slide, please. I now want to shift the needle a little bit and move away from the issue of scheduled 1 and 2 medication and what we've described in that space. And I want to spend some time, a few slides, on South Africa's quadruple burden of disease, namely the non-communicable diseases, HIV and AIDS, injury and trauma, maternal and child mortality. And I want to suggest that a huge opportunity exists for self-pay in these critical areas. So the impact that pharmacy can have in assisting to overcome the burden of diseases is substantial if we focus our energies on the right of the slide. So if you move towards the right, you're looking at long-term conditions, some acute conditions, mental health, for example, and other major trauma issues outside of the first part of this continuum, which is the lifestyle issues and self-managed ailments. Next slide, please. So the first of 2 or 3 case studies that I'd like to do. The first is Kamba Yashanga, which is in Swahili, a string of beads. And this connects healthcare partners, including the pharmacist, the physician, taking technology and utilizing the expertise of pharma along the patient's healthcare journey. Next slide, please. So using the clinical skills and ease of access, we attempted to reshape the patient's asthma journey, creating self-care knowledge and ensuring clinical outcomes, all of which resides in real world evidence data. So all of this is managed through a data system, through a platform, and we can then start to engage with the results and outcomes out of this. The next slide, please. The ecosystem allows us to educate patients to take control of their asthma through medication use review, perfecting inhaler techniques, creating action plans, and formulating a referral network with other members of the healthcare team in a joint operation. Next slide, please. The next of my case studies relates to other major disease profiles in South Africa, which is TB, HIV, and AIDS. To this end, we've designed in partnership with the Southern African Clinicians Society through a USAID grant, the first pharmacist qualification to initiate and treat first-line ARVs, as well as initiate PrEP and PEP. Combined with that, we make test kits, very much like what Danielle has described, freely available in pharmacies through a project called the STAR Project. And this is in partnership with Wits University that ran the training program and Unit Aid. In an attempt, we've also tried to pilot a TB routine screening program in pharmacy clinics. So these are some of the initiatives that is talking to shifting us out of the framework of the Schedule 1 and 2 into the non-communicable spaces and other conditions. Next slide, please. So pharmacy safe spaces is an important part of our attempt to assist stem the tide of gender-based violence in South Africa. Our partnership with the Psychological Society of South Africa provides a quick referral system for free counseling for any person that might have encountered gender-based violence that might come into the pharmacy and utilize the safe space. As the slide demonstrates, each participating pharmacy is provided with a full resource toolkit that is required to easily participate and ensure that those that seek the service is well managed in the program. Next slide, please. The last of the case studies is the issue of maternal and child care. Pharmacy plays a key role in maternal and child health care through care and support via numerous projects. And an example I'm going to give you is the baby immunization and sexual and reproductive health in the Western Cape. So in this province, we have engaged with the Provincial Department of Health, and just in the year 2019, we didn't get any data out of 2020 yet, but in 2019, we provided 350,000 primary care services in that single year for the province. Pharmacists interact with 100,000 women a month, providing the morning after services. Now, tied to this, we are trying to bring in the PMAT program to say we've got a captive audience of people who are utilizing services, and we could have an easy conversation with that. My last slide in conclusion. Next one. So in conclusion, our interaction with the over-the-counter medicines must be transformed into a structured ambulatory service. There is an opportunity to integrate self-care and customize it to meet the country's healthcare needs in areas outside of medicine supply. And lastly, we have an opportunity to engage the three missing pillars, I think, of self-care in strengthening knowledge and health literacy, mitigating the current self-care risks, ensuring a more rational use of product and services outside of the other four pillars, which most people manage themselves or with the assistance of their healthcare professional, which is mental well-being, physical activities, healthy eating, and good hygiene. Thank you very much for listening. Take care. Back to you, Andy.